Right. Last lecture this year is on the auditory cortex. So we've worked our way up the auditory pathway from the cochlea. We smile at the auditory filters now, and we know all that we can know about auditory functions and about the physiology and the neural functions of the auditory perception. And we talk about the aging auditory brain. So what we know a little bit, this is just a really rough overview, what happens when the brain gets older and when we lose our auditory functions. Right, here's an anatomical map of the brain. This is a picture of a fresh brain. Still has its natural colors. So we've got the general separation anatomically into frontal lobe, parietal lobe, occipital lobe, cerebellum and temporal lobe. These are based on these fissures that are the most prominent fissures that you can see. So if you have a brain, it very much looks like a walnut, but it's actually more structured than a walnut because it has these, it's always very, very similar kind of fissures, these sulci here that you see, and they determine. They have the same color and the same appearance when you look at them, but they determine just looking at it the rough geometric position. The cerebellum is very different. It has a much finer structure than the whole of the cortex, and it has a completely different function as well. We are talking about the auditory cortex, everything which happens here on the temporal lobe, and unfortunately, well, it doesn't really matter if it's fortunate or unfortunate for experimentation, is actually happening all inside, because this is actually a fold, and most of the auditory things happen on the inside of that fold, so you can't actually access it from the outside. Okay. Anyway, here's some facts about the cortex. It consists of grey matter surrounding the deeper white matter. Talked about these two things. The white matter is all the connections. They're the nerves, they're the myelination that make up the white matter. So they're actually not the nerves that you see, but you see the Schwann cells that are white. The neurons themselves are grey in appearance, and when you see grey matter, that's where all the processing happens. That's not where the connections happen. The grey matter is actually, we don't talk about the horizontal layers here, but the structure of the brain is as such that all the connections go to the inside and all the processing effectively is on the outside of the cortex. Cortex is Latin meaning shell, and it just refers to the outer 1.5 or 4.5 millimeters of the brain. And this is where all the processing, the important processing, happens. Right, go through that. Gross anatomical divisions of cortex by the 4 skull bones. That's what I didn't say here. If you look at the skull, so from the outside, it has what do you call them? Cracks, breaks? No, where they meet. So if you have a baby, then the skull is very small, and it grows outwards from the what do you call them? Where they are fissures officially? Okay, fissures. So in the fissures, they actually are on top. We don't see that here. That's the main one, front to back, and over there as well, through the Sylvian fissure. 4 skull bones, yes. Right, we've got the further division by the sulci or the gyri. Right, the cortex is only the one outside layer, 1.5 to 4.5 millimeter. It is said that if you put the cortex on a flat surface, it would cover something like 1.5 to 2 square meters. It's quite a lot actually, but you see the problem is that obviously you have a 2-dimensional structure within a 3-dimensional environment. And the way to fold it up is the way that what we see here. This is where this convoluted structure comes from. Because all these fissures, these sulci and lobulars, come from the fact that you want to increase the surface. It's exactly the same there for a walnut, in fact. You see that evolutionary as well. If you have animals which are slightly lower on the evolutionary tree or smaller brains, their brains are flat, like a mouse or a cat or even a pig or a cow. Look at a cow's brain, it's about that size, and it's basically flat. It starts having convolutions like that if you go up to cats or dogs. They have 3 or 4 of these sulci, and then monkey brains look pretty much exactly like ours in a smaller version. But the human brain is the most convoluted, apart from others. There are animals that is usually thought that the human brain is the biggest in the world. That's by far not true. There are a number of animals that have much bigger brains than humans. Elephants, for example, or blue whales. Blue whale brain is that size. Dolphins as well. That tells us something. Intelligence is not connected to brain size, luckily, otherwise old women would complain in this room, hopefully, because women's brains are on average a little bit smaller than men's brains. That has nothing to do with intelligence, but there is a very linear connection between the size of the brain and the size of the body, for the simple reason that the brain, as we see in a slide in a minute, is a representation of the physical entity of the body. So the bigger the body, the bigger the brain must be, because you need to somehow represent all the brain, all the surface area of the body in the brain. Anyway, it consists of 6 horizontal layers, which we're not going into detail. It could be a lecture in its own right. The outermost is horizontal connections to other brain areas, very well known. Layer 4 is the one that projects into the brain, and layer 3 are the one that gets all the connections from below. But we don't really care about that. Here we don't really go into much detail of the functioning of that. It has, although it's only that thin, it contains 80% of the brain's weight. So that gives you an impression of how important it obviously is. So the cortex is where everything happens. Well, apart from the brainstem, obviously, where a lot happens as well. But if you go up from the brainstem, radiating the information out to the cortex, then this is where all the processing happens, in this outer 1, 2, 3 millimeter. It's very densely packed with neurons. It's about 100,000 neurons per square millimeter. If you calculate that by, 2 square meters, you get a number of a few billion nerve cells that are actually doing the work. Yes, fibers radiate up from brainstem thalamitic nuclei to the cortex. That goes into the 3rd layer, and it is, we call now, the last link in the efferent pathway. So our auditory information went up from the auditory nerve. Here it ends, but not as simple as that. Functionally, we know that the auditory cortex is certainly involved in thought and perception and all higher functions of the brain. So in fact, if you're under anesthetics, what is anesthetized is only the cortex, but not the brainstem. If you anesthetize the brainstem, you're dead. If you anesthetize the cortex, you just sleep, which is nice because it's very useful. You don't feel any pain or anything, basically asleep, but the brainstem carries on working. So the cortex is a bit of an extra, if you like. It is not the bit that do all the vital tasks, but the ones that does all the fun things. Right, in humans, we have a difference between the left and the right cerebral hemispheres, and the human is the only animal, in fact, in the animal kingdom that has this separation. You'll not find any chimpanzees or other primate that actually does a separation between the left and the right hemisphere. In humans, they are very much different. We see that in a second, that we talk about the left and the right auditory cortices, that they do different things. We have maps of specific areas. We've got a figure on that on the next slide. And we separate 3 different areas that are mostly relevant. One is the sensory areas. That's for receiving and processing sensory information. These are always going up for the primary and the secondary, maybe tertiary. The primaries are the ones that directly get the input from lower regions. So I've got the primary auditory cortex, primary visual cortex, and so on, always the primary cortices. The secondary ones are the ones where this primary 2 radiates to, tertiary even further, and so on. We've got the sensory areas, we've got the motor areas. They're the ones that control our physical body functions, the muscles. and the association areas, which are probably like half of all the areas. And every time we say, did I say that already? Every time we mention associate areas, it basically says we have no idea what they're doing. They associate somehow the two with each other, the sensory with the motor, and they're doing the thinking processes or the integration of the sensory information. Right. This is the standard mapping, which is quite old, developed by a guy called Brodmann in the beginning of 20th century, and he did that only at looking at under the microscope and noting that there are slightly different looks of the cell types and the thickness and the connections and other things of the neurons in the different areas. So, for example, the area number 10 is slightly thicker than the area around it and that area, and there are slightly different cell types in these ones as well. And so he did these maps, just ordered them into different and bit boldly put these dotted lines around them and said this is a different area, probably doing a different thing from there. And he had no idea, that was way before any functional neuroimaging or anything. So this is just purely on the anatomy, but it turned out that these areas are very useful to describe the functions. That's way above what he actually wanted to do. That's about the time when people thought about, what's it called, craniometry, that you're looking at somebody's head and they have a big area there, and then you say, this must be that area, and so they must be very devilish people or so. And so they were trying to associate people's behavior with just the look of their brains, which never really worked. We understand a lot better today what these brain areas actually, what the functions of these are, and they've got nothing to do with the personality types of the human. There's no way of telling the personality type of a person just by looking at their brain. There is a way of looking at a lot of functions, though, from looking at the brain. So the ones that we put in here, so this is not what Broca put in there, this is what we discovered much later, is that this, for example, is the premotor area and the motor area. So this is both of these areas together control all the muscles in your body, together with the cerebellum, actually, which is at the bottom down there, which we don't show anymore. The trick here is that the cortex is responsible for the broad movement. So that tells my left arm to move up. I have the intention of now moving up. But the cerebellum, so the bit that is at the bottom right hanging there, does the fine control of that. That takes a long time to set for a human to learn. I see that with my daughter, who's now approaching 2 years, and it is very difficult for her to grab certain things still, because it is so the muscle control of all of these muscles at the same time needs years and years of training. That's what the cerebellum is doing for. But the rough control comes from the motor areas here. We also have the taste areas down there, the auditory areas, which we'll talk about in a second, vestibular areas, and not to forget the whole of the visual area over there. The eyes in this picture are here in front. The visual area is back there. The ears are here, and the auditory area is there as well. But it shows that they're always across. So there seems to be a rule in nature that you have the areas that are in the cortex associated with the perception are always on the opposite side of the head of where they actually go in. Why that is the case, I think nobody really has a clue about. But that's the way it is. Right, so these 47 areas are still used today. So if you read literature on auditory cortices, they will tell you very often we were working in area 41 or 42, or they say primary auditory cortexes, but they are related to each other. So we're going through these areas, the auditory areas now, and give them the names. So 41 and 42, remember they're here on the Sylvian fissure, and they are actually mostly behind the fissure on the inside. 41, 42 is what we call the auditory, the primary auditory cortex. So this is where all the information from the MGB, from the auditory thalamus, medial geniculate body, ends up. it's involved in tasks such as identifying, segregating auditory objects, identifying location of the sound in space. Now we said that the location of a sound is sorted in the Auditory complexes, but here when we talk about cortex we talk about the perception of that. So there are two different things. If you have the best way to tell what a brain area in the cortex is doing is by losing it. Well, poor people who haven't got that. Stroke, for example. Stroke patients are great for developing theories about cortex, because there's a stroke means that a certain probably restricted area of the cortex is functionless afterwards. Even better, patients for that are actually victims of shootings. So the biggest part of brain development probably came in war zones, or in America where they've got lots of shooting accidents. Because people, if you have a shooting wound, it just may be able to take out a very small bit of the cortex, leaving everything else around intact. And you can tell from the function that people are missing what they were actually having, what these areas are about. Nowadays we don't have to rely on these anymore because of visualization techniques, obviously, MEG, fMRI and things like that, that allow to do that non-invasively, luckily. But nevertheless, most of the information that I give you here is actually collected from people that had accidents. Anyway, what I wanted to say is, if you lose 41 and 42, you still hear, but you're not consciously aware of that. That's the case with many of the brain areas. You're still able, because all of the auditory brainstem is still there, you're able to hear that there is something, you're able to hear where things are, and if they're basic information, you're able to hear if something is threatening or not, for example, but you're not consciously able to be processing it anymore. Right. Receives auditory information. It lies along the superior surface of the Heschel's gyrus, so that's here. Heschel's gyrus is that one. Borders the Sylvian fissure and is largely hidden within it. That's what makes it difficult in fMRI experiments to see, because it projects mostly to the back of the brain and not to the front where we would see it easier. It passes information onto area 22. Let's go back. See that? So these are the primary auditory cortices. The big thing around it, secondary auditory cortex. Here we go. Including quite a lot of the bordering areas, which have a specific name, namely Broca and Wernicke area. Right. These are important. The secondary cortex is not so relevant. The Wernicke and the Broca area get special names because they were discovered specifically from people working in speech perception. They are the ones that are only on one side. So specifically, they are for right-handers in 95% or something on the left side. For left-handers, they are also mostly on the left side, but in some cases on the right side. The damage of these areas here, I'm talking about mostly of the Wernicke area, so the posterior part of the area 22 here has its own name than area 44. That's the Wernicke area, and damage, here what I'm saying, if people have a stroke or usually stroke, in that area it will compromise perception of speech and errors in word selection, but not of the complex auditory stimuli. I've got an example for you what Wernicke aphasia is. So aphasia means if you have a damage in that. Yes, in the left side of the brain, that's the part where it is connected with understanding and generation of words. On the right side of the brain, it's doing something completely different. It's to do with music. So humans are the only creatures that have the ability to generate or to enjoy music, and they have a whole complete brain area responsible for that, and that's the right side of the head, where the left side is the speech generation. So there is a very close association between speech and music, because they're processed by the same part of the brain, but mirrored. Interesting story of somebody who has lost their ability to speak. because they had a stroke on the left side of the brain. There are described cases where people are still able to sing, although they're not able to speak, because singing is a musical utterance and is generated and processed in a different part of the brain than speech itself. Just trying to remember the name of the guy who's written all these books. The man that confused his wife with a hat is one of them. Somebody remember? Written great books on brain science and cortical sciences, and he works by describing weird cases. And there was this guy who actually really confused his wife with his hat because he completely has no recollection of objects anymore. But there's one example. There are hundreds of them. And he's got all these examples of people that can sing but not speak anymore, for example, or a guy who had a stroke and suddenly learned to play the piano within a few weeks' time and was up to world standard and was able to play piano concerts with thousands of people. And he managed to learn that in a few weeks' time, and nobody had a clue what that was about. There was even a BBC program on that. But I forgot his name. Come to me, sir. Anyway. I should put that on the book list. Yeah. Okay. Enough of that. Wernicke area is responsible for the understanding of speech, whereas the Broca area, so the other associated auditory area here, is responsible for the projection of speech. So that one is a lot more associated with the motor side, that one with the perceptual side. Again, left and in right-handers, most left-handers. And if it's damaged, you get a Broca's aphasia. You have specific speech impairment and the projection of speech, but not in the comprehension. And here I've got two examples from how people speak who have either a Broca, so a projection aphasia, or a Wernicke aphasia. That's an understanding or missing understanding of the meaning of words. So if you read that, it still makes completely sense what this person wants to say, but they do not remember the words or have problems speaking them. Whereas poor patient with the Wernicke aphasia confuses words. They don't really understand the meaning of a word anymore. Called my mother on the television. It's just it pops into the person's head that word instead of the right word, which probably is telephone. But this is what Wernicke's area is doing. So getting the right words understood, whereas Broca is getting the right words said. Okay, there is an old but always good fMRI imaging result from, you get nowadays, you get pictures which are much better, but it's quite a classic, because this is, fMRI always averages 20 or so patients. You put them into magnetic resonance image, so this is one of the machines where you slide in, you've got a big magnetic field rotating around. The magnetic field does resonate with your hydrogen atoms, and you measure the time that they take to get back into their magnetic spin. That's why it's high magnetic fields. And what you do with that is you measure the concentration of certain substances in brain. That's glucose. That gives you an idea which areas of the brain are active when you're doing the task. It's very time insensitive, so it's in the order of seconds to maybe minutes, so that the brain needs to be active there specifically to get a higher of these activities. So this is not something that is very fast. It's exactly at the opposite spectrum, by the way, of what we're doing with electrophysiology, because there we have millisecond resolution, but we only have one neuron. Here we're looking at 10 billion neurons, but we only get one picture every minute or something. Anyway, if this person, this average person, is viewing words, not doing anything with them, just looking at them, and I think they were nonsense words that don't make any sense. You know, they must have been nonsense words. None of our auditory areas are actually active because there's no auditory information going in, but the visual area is. as sort of a comparison, only relevant if you listen to this word. So this is the standard activity. If you listen to me now, all of your secondary auditory cortices are active, as well as the Wernicke area, which works very hard to make sense of what I'm saying. Broca area, not so much here in front. If you're speaking words yourself, the Broca area here, so primary, this is the motor area, and well, I don't actually know where Broca is. I think it's the mixture of here. So you're working hard to speak words and make sense of them. And I think Broca is that one here, because it is also active if you generate the verbs in your head without actually speaking them. So then the auditory cortex, that one, is quiet, but the Broca area is still used. So the auditory cortices are not only active if you actually hear something, but they're used for language generation. So the whole thing interacts, obviously. So the brain makes use out of the resources in the best way it can. And even if they're called auditory cortices, they're not necessarily only for hearing. The same is true on the other side if you play music, by the way. If you play a certain melody, you get an area, the Wernicke area here, active. If you play music, you get the Broca area, and this is in inverted commas. They're not called that. They're then secondary auditory cortices on the contralateral side. Okay. Here's my favorite map. This is a very striking image. It's called the homunculus. Is what the auditory, no, what the cortex would, how do you say that? If you cut through the cortex sagittally and you map what the function of the cortex is at a certain place, so you get from this is the midline, you go from the low to high, and you do that at about the sensory area, so where the representation of the body is lying. Then this is the representation of the different parts. So tongue has its representation here, teeth, lower lips, upper lip, face, nose, eye, thumb. Here is a jump, which very interestingly, to the hands, to the arms, upper body, lower body. Now, interestingly, several things interesting. First of all, these are completely different in size. So the lips have by far the biggest representation. Why is that? Because they're most sensitive. You've got the highest concentration of sensory nerves in your lips, many, many, many more than anywhere else, say the eyes or the index, even the fingers. Fingers are overrepresented by far more than, let's say, the wrist or the forearm here. So you have in a square millimeter of your lips probably more sensory neurons than in the whole of your lower arm. And you need them as well, because they're very important for feeling and food and everything. And so this is where this homunculus comes from, because this is representing each area of your body with how much it is represented on your cortex. It also shows you how sensitive you are. So you're most sensitive at your lower lip and your hands. They are much, much more sensitive than, say, your feet, for example. So this guy is called homunculus. It's like the brain representation of your body. Homunculus is also the name of the guy that we usually call the guy inside the brain looking on the outside. I like this concept because nobody really has a better concept of how consciousness works, but we're not getting into this discussion here. But I always imagine there is somebody sitting in my head looking outside, somehow working with the cortex, but this is this guy here, the homunculus, that sits in there, and this is how he controls your body. Anyway. Yes, I just want to make the link back to the auditory system, because this representation is exactly the same as the tonotopy that we were talking about throughout the auditory pathway. So the tonotopy, the representation of the cochlea, is a tonotopic or a spatial relationship which is protected all the way up to the cortex, exactly like here. We've got this neighborship relationship. So things that are neighboring here are also neighboring on the surface of your body, and things that are neighboring in the cochlea are neighboring on the cortex as well. But you have jumps, certain jumps here. And there are curious cases where you actually get cross stimulation between these, especially if there's something going wrong. And there's a well-described thing that at the top of your eyes, the top of your forehead, actually elicits stimulation within your fingers that you can feel. And quite a lot of people have that, and the reason for that is that they are very, very much neighboring on the cortex. Anyway, and now to something completely different, and I'm way over time here, namely the aging in the auditory system. And we go through the auditory pathway from the external ear right to the primary auditory cortices, and talking about what happens with presbyacusis. That means when you're getting older. Presbys, Latin, old man, acusis, hearing. It is just a description, it doesn't indicate the etiology, it just means that's what happens if you get older. These are the prevalences of hearing loss in the UK. You might have heard these in different lectures, probably in more detail. I just put that on here to motivate the whole of the thing, because, well, not so much that one, because this is not age-related, just showing that 7.6 million people have a hearing loss of 25 dB. That's across all ages. But more to the point, the prevalence as a function of age, so 65 plus, we've got 290 per 1,000 persons, so that's about a quarter. So obviously there's something going wrong with the hearing over time, which is quite dramatic. And I think it's more noticeable than in many other, well, it's probably as noticeable as in other sensory areas as well. Let's go through the auditory pathway, starting with external ear, inner ear, cochlear nuclei, up to the cortex. What's going on? Outer ear, what happens if you get older? Collapse of cartilaginous external canal. Gets floppier, excessive amounts of ceramum, that we can deal with. Hair growth, enlargement of pinna, because you lose the stability. That all contributes, it changes the head-related transfer functions, it makes localization worse, but it doesn't contribute to hearing loss significantly and can be easily counteracted by hearing aid. So that's doable. Middle ear is more tricky. We have the effects, stiffening, thinning, and loss of vascularity of the ossical chain, and the basilar membrane as well. We have atrophy, degeneration of the middle ear muscles and ligaments, and we've got ossification. So that's the process of calcification of the middle ear bones, so they get stiffer, and so the whole of the transduction chain doesn't work anymore. That has a small contribution change of hearing threshold, mainly at higher frequencies. But it's a conductive hearing loss, so it mainly influences the thresholds, but not the filters. So this can be counteracted by hearing aid as well. Right, cochlear hearing losses are more interesting. I usually split into 4 different ones: sensory, neural, strial, conductive, or a combination of all the above. And let's talk about them in a little bit more detail. Sensory, in brackets, age-related hearing loss, is the loss of the sensory, so usually the inner and the outer hair cells, and also supporting cells in the basal end. Usually happens first on the first 10 millimeters. It is probably a result of accumulation of noise trauma over time. Outer hair cells are usually affected first, which results in a loss of a widening of the filter. And the typical threshold for these is the sloping high-frequency hearing loss, so anything above 2000 Hertz, the first 10 millimeters of the basilar membrane are affected by that most. Yeah, pure sensory age-related hearing loss. We usually don't find that, because usually they are together with other hearing losses, specifically the neural hearing loss, which is everything that is related to loss of spiral ganglion cells. That is impossible to diagnose without cutting open the cochlea, but you do see it in the loss of general of thresholds and widening of filters, but it's very diffuse pathology, so you can't easily identify that. Easier to identify is the strial hearing loss caused by the atrophy of the stria vascularis, so loss of tissue and cells, so this is less supported with potassium. Due probably over time to free radicals, although I put a question mark over there because I'm not an expert in this metabolic chemistry going on in there, but this is what at least a few years ago people believed, that the free radicals have a most effect on that. It does change the iron concentration in the endolymph and will result in a flat hearing loss because it mainly influences the inner hair cells, still with good filters, so you have remaining a good speech recognition. Flat though, because it affects all the different from the conductive hearing loss, for example, which goes highly, mostly to the higher frequencies. Flat throughout all frequencies. Okay, conductive hearing loss of the basilar membrane. That's not conductive of the middle ear, but of the inner ear. It's the loss of the elasticity of the basilar membrane, and usually that happens for the basal end of the basilar membrane, high frequencies again. That happens due to the diminished attachment of the spiral ligament, and it's largely speculative because there's no way of looking at that even under the microscope. That's more a theoretical one. Typically what happens, what you see in practice, is a mixture of all of the above, and so therefore you say mixed sensory neural hearing loss, because they're the most common types, sensory and neural ones, and every manifestations of a hearing loss is a mixture of these two mainly. Okay, here's an overview. Sensory hearing loss, loss of the sensory cells in the basal turn, and as a result you see a sloping high frequency hearing loss above the frequency speech range, or pretty much in the middle of it actually in most cases. Got the neural hearing loss, which goes into with the loss of the cochlear neurons. That will result to progressive loss of speech discrimination in presence of stable pure tone thresholds, which means it does not affect so much the inner hair cells, but it affects the amplification process as a general, and all the filters become a bit wider. The strial hearing loss, which goes with the metabolic and vascular changes within the cochlea, that affects mostly the inner hair cells, so the filters stay the same, but we've got a flattening of the audiogram. And the conductive one, which I said is mostly speculative. I don't know how you actually see that in an audiogram. So the combination of the mild to moderate high frequency loss, usually as a mixed hearing loss. Yes, clinically they are difficult to identify because based only on the audiogram, and what we also can do with speech tests, you can make assumptions of these, which help you to identify or to inform the patient. But in most cases, it doesn't really help you to suggest a remedy for that. But there we go. At least we know where they come from. Also important for the aging brain, the aging population, are what's called the central effects of aging, CEBAs, the central effects of biological aging. There's a lot more going on in aging than just on the cochlea. The cochlea, of course, for our auditory processes is the most relevant, the most important aspect, but the central effects are, they're more subtle, but equally important, because they affect communication skills of people or the way that they behave socially. So what happens biologically? You have a decrease of numbers of neurons in the cochlear nucleus and other auditory centers. You have generally a decrease of neurons within the whole of the brain. So neurons don't generate each other. They're the only neurons, they're the only cells, or one of the cell types that don't regenerate. So once you lose them, they will not be regrowing, because you haven't got the stem cells that are responsible for that. So once you lost it, it's gone. They also overall shrink Why that is the case is not quite clear. The argument has been made this is about efficiency. So when you get older, you don't build the number of synapses anymore that you have when you're a baby. In fact, the number of the synapses is maximum when you are at about 1 to 2 years old. And from then on, the number of synapses continuously decreases in your life, which means that what you have learned is more established, but it's also less plastic. And you can make the case that if you don't make any more synapses, your neurons don't have to have the same volume anymore, they can actually shrink a bit. So the overall volume of the brain reduces as well. And you also have changes in neurochemical makeup, which means that they don't necessarily function as well anymore, specifically in the temporal domain. And this is where it's becoming important for audiology, of course, because if you lose the temporal precision, most of the brain doesn't really care about that, because most of the brain doesn't work as fast as the auditory neurons. We talked a lot about the temporal processing. You can discriminate a 1000 Hertz tone from a 1010 Hertz tone by measuring the difference in a few microseconds between the intervals between the spikes. Now if you get older, this precision gets lost and you get problems listening to pitch then obviously, but all auditory processing. Yeah, general age-related pathologies may affect the auditory pathways. This is arteriosclerosis, so the stiffening of veins. Anoxia is oxygen loss, metabolic dysfunction of the liver, free radical-induced damage, like in the strial auditory damages. That all has an impact. Is also a potential genetical impact. That's quite obvious actually. Hearing loss does run genetically in families, that's well known. But it's not clear if the overall effects of aging on hearing are an effect of central effects or of peripheral pathology. I have a mixture of here. So that if you lose neurons in the cochlear nucleus and you have a problem processing the speech, is a different pathology from you have a loss of neurons in the cortex and problems understanding the speech. And it's very difficult to unmix these two effects. Okay. List of drugs that might lead to hearing loss by accumulating over lifetime. Talked about them already. You will have heard about them in the pathology lectures. Aminoglycosides, this is part of antibiotics. Quinine, I don't think that is used very much anymore. It used to be a remedy for malaria, exactly, right up to the 60s, but it's not used anymore. Beta blockers, diuretics, non-stereo anti-inflammatory agents. Salicilates, that's the killer here because this is in aspirin. And I'm following that debate with interest because there is every now and then in the Daily Mail an article that aspirin, you should take 1 aspirin a day because it's good for you, because it prevents heart attacks, because it dilutes the blood, but it has a lot of side effects in the body, and one of the side effects that because it dilutes the blood, it is has a negative effect on your inner ear of the stria vascularis because it is antioxidant there. And so, I don't know, you want to get deaf or you want to have a heart attack, you decide. There must be better ways to do that. Anyway, effects of hearing loss. Yes, that's quite obvious. I think that's the summary slide of the whole of the lecture series. Hearing aids will not always fully restore hearing, because even if you lose all the auditory cells, even if you have still your filters, they get broader. You shift up the threshold, the filters get broader, and when you have background noise, all of the energy of the outside gets into the filter, and you will have problems understanding speech when in background noise. And because of all of that. Okay, one slide on cognitive aging, 2 slides in fact. Older people often have problems with executive functions, with planning, organization, creativity, innovation, problem solving and fluid reasoning. And that all affects functioning, auditory functioning as well, because if you do a test with them, like a speech test, I mean, PTA is so trivial that people usually get it, but I had people in experiments where you had to explain things 3 or 4 times, and they don't really quite understand the task, especially when it's a little bit more complex task, more complex than pressing a button, and it is about speech test. Then what do you say? Do you say they have a problem hearing because they don't perform the task? Is that because they don't hear it, or because they haven't understood the task, because they can't, because they're missing all of these functions? That's a clinical problem with you if you have old people in your clinic, obviously. So we can't solve that, but it's quite not clear where this all comes from. But there are several explanations of what happens in the old brain, in the old age brain, to get to this problem. One of the structural breakdowns is synaptic communication, because individual neurons die, they take their synapses with them, so you've got just less of them, and you might miss some of the communication in the brain. You've got a breakdown of neurons leading to this, and you've got potentially functional changes in the brain. So brain areas that are responsible for one area may be taking over other areas, or just not functioning as well anymore. Here's a little overview of the cognitive disorders, just as a kind of information of what we're dealing with. We've got everything from age-associated memory impairment, that has pretty much everybody, not quite, right down to Alzheimer's disease. And on the way we discovered the age-associated cognitive decline, which is something like 1/3 in people aged 65, and it leads to dementia in many cases. So this is a pathway from there to the dementia. We've got the mild cognitive impairment, leads to dementia in 50% of the cases, and we've got a prevalence only of 3 to 6% here, age 65, but it does lead to dementia. Dementia is just the general terms describing persistent dysfunction of cognitive domain. So that's not auditory, but everybody who has auditory problems might have dementia as well, of course. The definition of these, by the way, just put the definitions in most of them, is usually you do a cognitive task. You don't measure them, other people do that, but if they do that, they measure a cognitive task and they get a normal distribution of these, and if you're 2 standard deviation below pairs, that is 95% criteria, you count as having dementia. It's not a yes or a no, it is a gradual, a little bit to a lot, basically. Dementia is I think this is still sort of a normal functioning of the auditory, of the old brain, which happens to the breakdown of neural and synaptic communication in 5% of the people, which is completely different from Alzheimer's disease, which is an actual manifestation of a disease, which is with the prevalence of only 3%, but 50%, 85 plus. Right, these are nothing to do with specific auditory processing, said that, but must be taken into consideration if you see somebody, old person, because if they're able to wear a hearing aid or use the hearing aid, might depend on their cognitive functions, obviously. Where this comes from, this cognitive aging, is not quite clear. Apart from this general term breakdown of neurons and communications, why they do that is really completely up for grabs at the moment. What we know is there are these well-known tangles and plaques found in Alzheimer's. Now it has been shown that they also find them in normals. You have got these this is connected to aluminium. You might have heard that you've got a high number of aluminium plaques in the brain with Alzheimer's. But that also has been shown recently that is actually in normals as well. So what we assume generally is that there is a breakdown of the functional interaction or communication between the brain areas, which is measured in a relatively novel technique, which is QEEG. That's qualitative EEG, where you not measure the strength of a response in the brain with the EEG, but the strength of the connection between two brain areas. And you see that in old people the connections are slower between the brain areas and less coherent. So you've got more activity which is spread across the brain. But there's a good news to end the whole lecture on. Cognitive aging is not inevitable, and it has been shown that factors that reduce the risk of cognitive decline: absence of chronic disease, complex and stimulating environment, flexible personality style at midlife, high intellectual status of spouse, and maintaining a high level of perceptual processing speed. So it's up to us to actually maintain of that. All of us can at least look for an intellectual spouse. Apparently it helps. What the reason and the consequence of that is really obviously not clear. But there you go. But the take-home message is use it or lose it. If you use your brain when you're young and when you're not so much young, when you're middle-aged, there's a high probability that you're fit when you're older as well. In doing auditory tests, these deficiencies must be recognized, because you need to be able not only to tell that a person has a hearing loss, but what they are cognitively able to actually do with it. Because not everybody is able to use a hearing aid, and this is the general disease of the NHS as well. Don't know what the last numbers of that is, but about a third, I think, of hearing aids that are prescribed in the NHS go into the drawer and will never be taken out again. And that's a bit pointless, because you spend a third of your time on something which is useless. And if you identify that relatively early on, you might be able to help people much more efficiently, either by not giving them a hearing aid, I don't know, you don't have them, by giving them a better advice and to tell them that this is actually the case. You need to be aware of that as audiologists, obviously. Okay, that was the end of this show. Sorry for being a bit over the time.